Hi guys, Dr. Dan here, your clinical dementia specialist. I hope you're all doing very, very well. I hope things are good for you. Today, we have a series of questions that have been submitted by our subscribers and viewers. So my beautiful wife and practice manager, Lynn, has whittled them down to 10 or 11 questions so that we can fit them into the time frame. If we do another Q&A at any other time, then we'll include the other questions. But for now, we've whittled it down to the 10, 11 important questions, or at least Lynn has. Hi, Lynn.
Hello.
So let's crack on with the questions. And I think it's a combination of clinical questions and some caregiving questions as well. So should be something for everyone here. And it might answer some of the questions that we haven't got time to get to today. Okay, Lynn, she's going to ask the questions because she's very eloquent and a great question asker, and I'll do my best to answer them.
Okay, first question. How can caregivers grasp the importance of empathy and compassion?
Great question. Empathy and compassion, what does it mean? That's where we need to start with that, I think. What is empathy and what is compassion? And how do we put ourselves in the shoes of someone else? It's very, very difficult to empathize with someone if you're not living it, if you're not there with it, if you're not part of the journey. Obviously, caregivers are part of that journey. And as we've spoken before, the whole aspect of dementia is a journey. It's a journey for everyone that's on it. It's like a movie, with the individual who is living with dementia being the star of the show and everybody else being the supportive cast. So the thing is that the way that we can empathize with somebody is quite simply by, I say simply, it isn't all that simple, but by fundamentally trying to understand what it is like for the other person in the other person's world. Okay, so I may be the person living with dementia. Lynn may be my wife who is supporting me through that journey. We're both experiencing different stresses, different situations, different challenges. So it's really important that each one of us understand what those challenges are, because I always tell people when they start that journey, if you are caregiving for your husband or your wife or your mother, daughter, father, son, always remember your own identity. So Lynn is Lynn first and foremost. Then she's my wife. And then she's the mother of the kids. And she may be, I know she isn't, she'll kill me if I say she is, but she may be a grandmother and things like that. And then she's a caregiver for me. She is not a caregiver first and foremost. Okay, so try and understand each other's journey, and that's one. And there's different forms of empathy as well. So if all you guys who are listening to this want to go and research empathy and look at the different types of empathy, then you will probably get a better understanding of where I'm coming from with that. Where compassion is concerned, I don't really know how to answer a question about compassion. Most people are humanitarian. Most people are very compassionate. Some are not. And the ones that are not, I guess, are the ones who don't understand this journey fully. And through education and through understanding and support, we can develop our compassion and move from that kind of direction. Okay,
next question. Is there a cure for any type of dementia?
Good question. Great question. We split it into primary and secondary dementias. So primary dementias are the ones that we all know about: Alzheimer's disease, vascular dementia, Lewy body dementia, Pick's disease, CJD, and all the primaries. So no, there is no cure. at this moment in time for the primary dementias. As we've talked in the past on other videos, there are ways in which we can slow down the progression of the disease. Some of that is a pharmacological approach, and some of it is a non-pharmacological approach that work together hand in hand. Secondary dementias are things that can be cured, that can be reversed. And these are things like, I should give one example here because we don't have a lot of time, but normal pressure hydrocephalus, NPH. That is a form of dementia, but it's a secondary dementia, and it can be changed around. You know, the normal pressure hydrocephalus, there is too much cerebrospinal fluid built up in the nervous system, and therefore it floods the system and people develop all the symptoms of Alzheimer's disease. By fitting a shunt and by managing the fluid, by draining it off, it drains into the stomach and gets absorbed into the body, and the person then goes back to not having any of the dementia type symptoms. And there are other secondary causes of dementia as well: infection, UTI, cancer, many other diseases that and illnesses that can be changed and reversed.
Okay, next question. At what point should I consider moving my loved one into memory care?
Okay, this depends on a number of factors. Number one, we always advocate, and everybody wants to age in place. If the resources are available for people to age in place, and by resources I mean financial, I mean family constructs, the dynamics, are the people there to help, are the people there to support that individual, are they open to having caregivers coming in and out of their home, are they open to maybe having somebody living in their home? There's a whole bunch of variables there, a whole bunch of factors that feed into when should somebody, or if somebody should move into memory care. And of course, the point where that question becomes really relevant is when people are not coping, when it becomes dangerous, when people are at a high risk of falls, when people are not there to support, when caregivers are inconsistent, when there's no opportunity to develop a relationship with in-home care because, you know, the rotation of staff is quite high. Those situations and circumstances feed into all that. But we always want to age in place. I want to age in place. Well, actually, my wife would say that I am actually aging in place.
You're aging in front of our eyes.
And so most people, when you ask them, they would prefer that, to age in place. If the resources are there available and it is possible to continue to do that, then always work on that. Yeah, Lynn, you want to add something to that?
Yeah, so, but I think the question is more about at what point. And I'm thinking of some scenarios of some past patients of yours when, let's say it's an elderly couple and one of the people in the couple has the form of dementia and they're falling and the spouse can't get them up safely or can't bathe them or can't help them, or I mean that's one of the major factors, isn't it, is that
right. Yeah.
And if they can't afford caregivers or the spouse, a lot of times the spouse is still working full time and they can't be at home to help them, but is recent hospitalizations or an increase in hospitalizations, an increase in doctor's visits, are those signs that maybe there's something that says they need to not live at home if not able to?
At the end of the day, it comes to when it is not safe to stay at home. For whatever reason, those reasons that you mentioned, those reasons that I mentioned, whatever reasons and factors, when it comes to the point that it isn't safe to stay at home and the resources aren't available to improve that safety, then that is probably a time when people start discussing the transition. And of course, last week we did a whole video on managing transition when people are moving on from home to a care facility.
Okay, here's a question about demographics. Who gets dementia, more men or more women? And then what race does it affect? Caucasians, African Americans, Hispanic people, Asian people?
Okay, we see more prevalence rates in females, and there could be a number of reasons for that. One of the biggest reasons is that females live longer than males. So there's a higher prevalence of females living longer, so therefore going on to develop a cognitive decline. The other part of that question is who? Well, Hispanics and African American people are at a higher risk of developing Alzheimer's disease than other people of other genders and races. Why that is, we're not overly sure, but that's what the research shows. And when we break it all down, we want to think about who are the people at greater risk. And it comes down to people who are over the age of 85. The prevalence rates increase massively, so it might be 1 in 5 or 1 in 3 even of people who will go on to develop dementia after that age group. Think about, we said women, females, also people who have diabetes. Diabetes is a risk factor.
Type 1 or 2?
Both. So diabetes is a risk factor. People with Down syndrome, if people with Down syndrome live long enough, then they are more than likely to develop Alzheimer's disease, and that's because of the link between the people with Down syndrome have an extra arm on chromosome 21, and we find the amyloid plaque on 21, chromosome 21, so there's a greater risk there. And then the final group of people are people who have a genetic predisposition to Alzheimer's disease, and they are people who carry the APOE4 gene, the apolipoprotein LL. So those are the risk factors, those are the risk groups. Okay.
Should spouses sleep in different bedrooms as the journey progresses? How do you know when you should? And again, I'm thinking of past patients that you've had.
Yeah, well, of course, we talked a lot about sleep, and it's always part of my consultation. We always focus on sleep, and it is important that people get sufficient sleep. So if sleep is being broken because of the other person, and because if sleep is being disturbed for either party, then there's strategies that need to be put in place. And those strategies are sleep hygiene and sleep quality. And we've got to make sure we've got strategies for both of those things. So when the sleep is being disrupted, and for whatever reason, then that is the time when people need to have a conversation about, should we sleep separately? It might be that you only need to sleep separately 1 or 2 nights a week, because that might be sufficient to catch up on sleep. When people get to a certain point in the journey of Alzheimer's disease, for example, the reticular activating system, which switches on and off conscious awareness, is broken. And when that's broken, that's when we have this break in sleep. People will lay down, go to sleep for a little while, wake up and get up and walk and go and do stuff all hours of the morning. So that is something that is very, very disruptive to both parties. So it's really important that we address those issues when they emerge, when they present.
And the spouse that doesn't have a form of dementia, I think you could stress, shouldn't feel guilty about going into another room to sleep, because I think a lot of caregivers put themselves at the bottom of the list of priorities. And I just want to state that they need to take care of themselves in order to take care of their loved ones. And getting quality sleep is not something they should feel that they're being selfish about. And if they're worried about their loved one falling or getting out of bed or something, there's bed alarms. People use baby monitors. They've come a long way, even in the last 10 or 15 years. There's a lot of methods you can use to do that. And plus, also the patient could have medications that change their sleep behavior, sleep patterns, and
it is important to make use of assistive technology, as Lynn alluded to there. There are a lot of companies that have made age-appropriate things for monitoring people, from bed mattress alarms to alarms on the rug to monitors and GPS systems and all kinds of really cool stuff that we are as a people's beginning to get used to in everyday life. So most people wear a watch, and most people now wear an Apple Watch or some kind of technological device which helps measure sleep and monitor sleep and all that kind of stuff. And things like a GPS tracking devices can be incorporated. There are special watches that you can buy that is GPS. So there's so many devices and so many assistive technology gadgets out there to help with that. But it isn't going to help with the actual medical side of not being able to sleep, and nor is medication. So when the reticular activating system is not working, no amount of night sedation is going to help the person go to sleep. So we have to think about how we're going to address those issues. But yeah, great points there. Good question.
Thank you. How do you explain to friends and family about the diagnosis? Let's say you've just come home from the neurologist and the diagnosis has been given. What do you share? How much information do you share? I think if I know you, you're going to say something about person-centered care and putting that person in the center of that decision.
Right, exactly. It is that individual's choice of when to divulge that information. Of course, I mean, it's private, it's confidential, it's protected. So it's down to the individual to decide when and who and how much information they are going to share with whom and when and where and why and how. Because there are so many implications in telling people that I have a diagnosis of mild cognitive impairment, or I have a diagnosis of early onset or young onset Alzheimer's disease. There's a lot of implications involved in that, in divulging that information. It can change relationships, it can change friendships, it changes the dynamics, it can make people feel more vulnerable. So there's a lot of things to consider and a lot of things for people to take on board before sharing that information. And if it's somebody who is still working, then there are different implications involved in that. So it's a big decision and it's a big thing to do to divulge that information. And whilst we are trying so hard to destigmatize dementia and destigmatize all the things related to a cognitive decline, there is still stigma there and people still feel it. And when you divulge something like you are in cognitive decline, that puts you in a very vulnerable position. Very vulnerable. And so you are always on guard about who I share my vulnerabilities with. So I just shared a post on Instagram today about making yourself so vulnerable you have to trust. And there's a picture of my horse at the weekend having her feet trimmed by the farrier, and she was standing there letting my farrier do her feet. And it made me think about trust. There is trust there because you're very vulnerable. When you lift a horse's leg, they are now on 3 feet. They're relying on 3 legs, but they are relying on you as well to support them whilst they're trimming the feet. So it makes you very vulnerable. And so my point there is about feeling vulnerable with an individual, but you must trust that individual in order to share those vulnerabilities. So I know that's a long-winded answer to that question, but it's a brilliant question. Whoever submitted that, absolutely fantastic question, because it is all about vulnerabilities and trust. And we have, in my practice, we have an acronym called HOT. We're in the desert, so we're always hot. But our HOT stands for being honest, being open, and being transparent. And so it depends when that person feels it's the right time to do that.
And I might add that if the person with the diagnosis is open to it, it would be maybe a good idea to start that conversation about planning financially for what might be coming ahead, because it's a good idea to have those conversations early or pre-journey as possible. We're all going to leave this earth at some point, so we should all be doing financial planning, but even more so when there's a diagnosis in hand. If you haven't gotten your affairs together and made some changes if necessary and make some updates, that's a good way to start that conversation, especially with adult children, I would think.
Yeah. Again, it's all about vulnerabilities, isn't it? Because you do open yourself up to absolutely everything when you share that kind of information. And it's like, terminal illness, terminal disease. How comfortable are people at sharing that information with family and friends? And the time has to come where sometimes they don't ever share that information. So yeah, great question. We could do a full video on that maybe in the future, because I think there's a lot we can talk about with that. Yeah.
Okay, next question. What is the best source of accurate information? Because as we know, Dr. Google is very present in all of our lives, mine included. But what is the absolute best source? What if you don't think, I know you're going to say your doctor, but what if you don't think you're getting the right answers from your doctor? What if you don't agree? What if they don't hear you or listen to what you're saying?
Right. Okay, when we're talking about a neurocognitive disease or a neurological disease, your neurologist or your dementia specialist is the key person that you rely on for accurate information. That can be validated through the Alzheimer's Association in the US and the Alzheimer's Society in the UK. Those two sources are your best sources for accurate, up-to-date information. Validate your neurologist, your clinical dementia specialist, validate their stuff by going to the 2 websites that I just mentioned there, or the organizations, because they are the leading organizations and services when it comes to research. A lot of the stuff we rely on is research based through funding by the Alzheimer's Society and the Alzheimer's Association. And they will release annually, every year there is a report, there is a document released by the Alzheimer's Society and the Alzheimer's Association about where we are in terms of dementia, about up-to-date treatments and therapies, about financial cost, about prevalence rates, about changes in demographics and all those kind of things. An annual report is always released by those organisations, and we all tap into those, and we rely on those a lot. Dr. Google, I mean, there are support groups and organizations out there and discussion groups where discussions, I have read some of the threads, and they go way off base, way off target, and it starts becoming people's opinions and people's experiences and people's beliefs and people's thoughts that start filtering into, well, when your mum isn't sleeping at night, you need to take her outside, walk around, then go back inside and give her some medication, and she'll go to sleep. You know, I've seen things like this. The threads just go way off base. So those are the places to go for that level of accurate, up-to-date information.
What's your opinion on a spouse or loved one of the person living with dementia doing research on their own? Do you think it's detrimental at some point to get bogged down in trying to educate yourself in every aspect? I know your answer, but what are your feelings?
I think everybody has to be educated. This is why we do these videos, because we want to educate the world and give up-to-date accurate clinical information, up-to-date accurate interventions and strategies and coping skills and things like that. So I think everybody has, I've lost my train of thought now. Research, education, we should all be educated. We should all know a great deal. We should ask questions. Always ask questions. Whether you think it's a silly question or not, doesn't matter. Just ask the question. Ask your doctor, ask the neurologist, ask your dementia specialist, ask your...
ask you.
Ask me. I'm your dementia specialist, so ask me, yeah. In England, we have something called an admiral nurse, who is a specialist nurse specialising in dementia. So you would go to talk to them, you would ask those guys questions. We have memory clinics in the UK where people are referred by the GP, will refer somebody to the memory clinic, where there's all kinds of people there. You've got a general physician, you've got a clinical dementia specialist, you might have a psychiatrist, a psychologist, social worker, all these different types, admiral nurses, to help and give you that accurate, up-to-date information. So those are the sources to go to, absolutely.
But do you think it could be detrimental to do too much research, to read too many things? Couldn't that affect their mood?
I think first and foremost, the most important thing is what's happening right now, today, what's in front of you. You can only deal with what's in front of you. And this is the present moment. Being present is what is important. The future hasn't arrived yet, so projecting into the future of what might happen, what might be, what might become, can be very inaccurate, because it's very subjective as opposed to being objective. So I think there can be too much information, there can be not enough information, and there can be a dangerous amount of information. So I think it's important that people follow the lead of people who have the knowledge. So the neurologist, the dementia specialist, the admiral nurses and the like. That's where you need to go for information and education. And Barrow Neurological Institute in Phoenix do a lot of education for staff, for caregivers. There's an awful lot of education. And I would recommend not so much support groups where there's no direction, but a support group that is educational. So the one I spoke about with Barrow, as you know, have guest speakers, will come and talk about stuff. So you're not getting one person complaining about something and then somebody else complaining about something, and then it turns into oh yeah, this is that and this is that and da. It's structured and it's educational, and people come away from those support groups with something practical that is going to improve their quality of life and improve the quality of life of the person that they're supporting.
And because dementia is individual to a person, not everyone's experience is the same. Everyone with Alzheimer's,
Right.
they don't all eventually do X, Y, or Z.
Right.
Only some do and some don't. So I think what I was alluding to is if you're reading too much, like you said, about projecting or predicting what might happen to your loved one along their journey, you're gonna maybe start thinking about things that are gonna be upsetting, that are unnecessary, because like you said, focus on what's happening today, what's in front of you, because you have no idea what could be happening next week, next hour.
Absolutely. And that is as I say to all my patients and their caregivers, that's no different to the rest of life. And each one of us, we don't know what is going to happen in the next 10 minutes, never mind the next 10 days, 10 weeks, 10 months. So focusing on the here and now is so important. Yep.
Okay. Last question. Cognitive testing. Should cognitive testing be repeated? And what about neuropsych testing? What's the difference between, let's say, a MOCA or a SLUMS or a MMSE and neuropsych testing? What are the differences, and should you repeat them, and why would you do that if you did?
Okay. So the key difference between a MOCA, an MMSE and a SLUMS compared to a full neuropsych test is that the first three that we mentioned there, they are quick assessments to determine whether or not we think there's a cognitive issue. And that will tell us, that will give us a clue, that will give us a hint. You can score 30 out of 30 on all those three tests. And if you score below a certain number, then that's indicative that we need to do further exploration. In the UK, you will be referred to the memory clinic, and the memory clinic will do all those tests. They will check everything. They will do all your physicals, they will do all your cognitive, your psychological, and determine at the end of the evaluation process whether or not you have a form of neurocognitive disorder, and if you do, then they will explain what they think it might be and how we're going to deal with it. Here in the UK, you will go and the test might show that there's a problem. So for example, if I do a cognitive function test, like a SLUMS or MOCA or a MMSE with one of my patients, and they give me concern, then I will very often refer them to a specialist over at Barrow, one of the neurologists or the neuropsychiatrists at Barrow. They will then review that and do an assessment and then refer the person for a full 4 to 6 hour neuropsych test. Whilst the SLUMS, MOCA and MMSE will tell us that something's not quite right here, it doesn't tell us what. It doesn't tell us what it is. So a neuropsych test does a full test of all your function, all your cognitive abilities, all your mental capacities, your mathematics, your language skills, and all those kind of things. That is accompanied, of course, by perhaps an MRI or an fMRI and maybe a spinal tap, blood test, and all these other battery of physical tests to rule out other things. And always with dementia, it's always been this case, it's more about ruling everything else out than ruling dementia in, because there are so many things that can present as dementia type illnesses, like we mentioned earlier. So there's the difference between those two. A neuropsychologist will carry out the neuropsychological testing. They will then feed that back to whoever it is that's referred that person for that test. And then, of course, we take it from there.
should these tests be repeated? Which one should be repeated and when?
Yeah, the neuropsych test, if it comes back as there's a problem cognitively, it identifies what is wrong cognitively. Is it to do with speech and language? Is it to do with numbers? So is it aphasia, or is it dyscalculia, or what is it? That's very specific about what it is. So you get the opportunity to address those issues. And then you may well, in 12 months' time, do another neuropsych test. Yes. In my practice, with a new patient, I very often do a MOCA or a SLUMS or an MMSE. My preference is the MOCA, which is a Montreal Cognitive Assessment Tool, which I really like. I enjoy using that one. And it's very user-friendly, and the people quite have fun doing it. So I enjoy that one. So MOCA is the one that I usually do at the start of treating a patient with my treatment plan, with my triadic approach. And then maybe 4 weeks later, I may repeat that cognitive function test to see if the score has changed. That's how I use the cognitive function tests. And then, as I said, the neuropsych test will probably be repeated 12 months afterwards.
Very good. Well, that's it for the questions that we have time for today.
Thank you. Those fantastic questions. So whoever submitted those, well done. Great stuff. Carry on sending them in. Send your questions. Ask us anything via Instagram, via Facebook, via my email address, drdan@drdanielnightingale.com, through our website, by contacting Lynn at lynn@drdanielnightingale.com. Anybody who wants an appointment, anybody who wants any clinical input, any support, please contact Lynn, and she'll make that happen. And I think that's pretty much it for this video. So thank you for your questions. Thank you for listening. Have a fantastic week. Live in the present. Live in the moment. And remember, guys, say it with me. Dump the soda.